Hepatic encephalopathy is the changes in behavior and cognition that occur in acute on chronic liver failure. It heralds a poor prognosis with mortality greater than 50% in the first year for patients with severe hepatic encephalopathy in the setting of cirrhosis. The pathophysiology of hepatic encephalopathy is incompletely elucidated. Serum ammonia is generated from protein catabolism and cannot be processed. At high levels, it crosses the blood-brain barrier. Glutamine synthetase is used to remove brain ammonia via conversion to glutamine, leading to elevated cerebroglutamine and lactate. Astrocytes become edematous. There is increased cerebral blood flow, cerebral edema, and intracranial hypertension. Severe cases of hepatic encephalopathy can progress to coma and death. Although cerebral edema has not been confirmed to be present in the early stages of disease, it may arise as a late complication. Seizures are rare, but they are a serious complication of hepatic encephalopathy. One study identified 15% of patients with encephalopathy who had EEGs performed that had epileptiform abnormalities on those EEGs. Our case is a middle-aged woman with a history of chronic alcohol use disorder, obesity, hepatic steatosis, and peptic ulcer disease who presented with jaundice, confusion, and increased somnolence. Her physical exam revealed scleral icterus, lower extremity edema, jaundice, asterixis, poor attention, and confusion. Initial laboratory workup was notable for leukocytosis, mild thrombocytopenia, increased creatinine from baseline, elevated alkaline phosphatase, hyperbilirubinemia, elevated INR, and a moderate increase in ammonia. This was consistent with acute liver failure due to alcoholic hepatitis. A CT head did not reveal any acute intracranial abnormalities, and CT abdomen and pelvis was concerning for emphysematous cystitis with hepatosplenomegaly also present. The patient's cystitis was treated with broad-spectrum antibiotics. Lactulose was used to treat hepatic encephalopathy. This was likely type A in the setting of acute liver failure, and rifaximin was added when her mental status failed to improve with lactulose alone. An albumin challenge was performed due to concern for hepatorenal syndrome. Despite multiple daily bowel movements with lactulose therapy, the patient's somnolence persisted, and she was placed on EEG monitoring. EEG revealed status epilepticus. There were no clinical convulsions. It was not known how long this condition had been present prior to the initiation of EEG. She was treated with IV lorazepam, which broke her status epilepticus, and then received an IV keprolode. She was temporarily transferred to the neurosciences critical care unit and emergently started on hemodialysis with slight improvement in her mental status. A repeat head CT and brain MRI revealed only moderate to severe nonspecific leukoencephalopathy. An IR-guided lumbar puncture was notable for an elevated opening pressure of 49 centimeters of CSF with benign cytology, cultures, viral autoimmune, and paraneoplastic studies. The patient continues to receive treatment to correct the reversible causes of her metabolic encephalopathy, as well as lactulose and rifaximin for her hepatic encephalopathy. She improved and was oriented to person and place as well as following simple commands, and she was discharged without requiring anti-epileptic medications. There are few case reports of non-convulsive status epilepticus in the setting of hepatic encephalopathy. Prior reports include a 2015 Korean case study titled Non-Convulsive Status Epilepticus Disguising as Hepatic Encephalopathy, and a 2003 Greek case report titled Status Epilepticus is a Manifestation of Hepatic Encephalopathy. This case highlights two possible dangers of hepatic encephalopathy. One, there is a risk that insufficiently aggressive treatment may lead to complications, including seizure. Two, there is a further risk that confusion due to the seizures can be attributed to the hepatic encephalopathy itself. In patients with non-convulsive status epilepticus, EEG may be the only way to differentiate the two diagnoses. This emphasizes the importance of having a low threshold for initiating EEG monitoring in persistently altered patients. Further investigation of seizures in patients presenting with hepatic encephalopathy is required. We do not yet fully understand how the chemical markers of hepatic encephalopathy lead to the cellular pathology. We do not understand which patients with hepatic encephalopathy are at risk for developing seizures, or whether serum ammonia can serve as a biochemical marker for this risk. In this case, a relatively high clinical suspicion for hepatic encephalopathy in the setting of acute liver failure masked non-convulsive status epilepticus. The case demonstrates the utility of EEG monitoring for patients with hepatic encephalopathy and the benefit of further research on this complication.